I would say there's really only two dermatome levels that you absolutely need to know, and that is that T4 corresponds to your nipple line, and T10 is at the level of the umbilicus. Everything else you can sort of approximate based on the distance between these two lines. I guess the lower extremity dermatomes are also pretty important, but covered extensively elsewhere. These are some of the common procedures that people will use Neuraxial for, and what different spinal levels you'll need to block in order to have a sufficient block for the surgery. So for a C-section, you need about a T4 to T6 block, which is actually reasonably high. For cystoscopy or transurethral resection of a bladder tumor, you need about a T10 block. For knee and hip replacement, greater than T12 will be sufficient. And an open inguinal hernia repair, you'll need a T8 block. We'll talk about the determinants of the spread of your neuraxial technique in the next video. For now, let's take some of this knowledge about our physiologic effects of a neuraxial block and put it to use. So let's say we're doing a spinal for a C-section, and we're going to target about a T6 level block. Just to simplify this right off the bat, let's say that we have not quite reached T4 with our sympathetic block. So although you may expect that your sympathetic block may be 2 levels higher, let's say that we're not quite at T4, therefore we're not blocking our cardiac sympathetics. If we're not blocking these T1 to T4 cardiac accelerator fibers, then we'll have generally preserved cardiac function. We'll be able to compensate for a lot of physiologic changes. However, our vascular tone certainly will decrease quite significantly. So we'll lose our venous tone, and this will cause decrease in our preload. And we will lower our arterial tone, and this will decrease our systemic vascular resistance. Therefore, we'll have a significant reduction of our mean arterial pressure. Now, because we're not blocking the ability of our heart to compensate, we may or may not have some compensatory tachycardia. And these changes are extremely predictable. So much so that most people will give some type of prophylaxis, namely phenylephrine, which is an alpha-1 agonist, which directly addresses our issue of low venous tone and low arterial tone to restore somewhat of a normal map. Just to note again that the respiratory effects of this are generally quite limited, although sometimes people will complain of dyspnea, which usually has more to do with the abnormal chest wall sensation that they feel as the block creeps up their trunk, rather than any significant respiratory dysfunction. Now to go over what happens when you have an inadvertently high spinal. So now we're going to include a sympathetic block somewhere in this T1 to T4 range, which means that you're going to knock out the sympathetic tone for your heart, which equates to unopposed vagal tone, decreased heart rate, and also lower contractility and lower drometropy, and potentially completely unopposed parasympathetic tone. So the most extreme vagal response that you can imagine, which includes possible cardiac arrest. You can technically braddy down to a heart rate of 0 and then fully arrest because of this. Meanwhile, you'll have all of the same decrease in venous return as you did when the block was the correct height. So you'll have preload issues and you'll have significant afterload issues which will probably just be more pronounced because your block is a couple spinal levels higher. And if this lack of preload becomes a significant enough issue, you can have such a significant reduction of your heart filling that you have a Physiologic reaction, or another thing to cause vagal or bradycardia. Remember, this is sort of a kissing ventricle reflex that exists. So when your heart is significantly underfilled, you'll become bradycardic in order to try to prolong the filling time of your heart. And actually, this Physiologic reaction can happen independently of a T1 to T4 block. This has more to do with the degree of preload reduction. In any case, when you have this unopposed parasympathetic tone, the best way to come back from this is an anticholinergic, namely atropine, as a strong and relatively rapidly acting anticholinergic medication that will decrease your parasympathetic tone. Before this atropine starts working, you may be so hypotensive that you get medullary hypoperfusion, and then respiratory depression or respiratory arrest, which is an uncomfortable situation to be in because when you're doing a neuraxial technique, you have an unsecured airway. So now suddenly you have an unstable patient with hypotension and respiratory depression, and you need to solve all of these issues. On a practical note, after giving a spinal anesthetic, you'll be very vigilant for any early signs of hypotension in between when your blood pressure cuff is cycling, namely nausea is one of the first things that people will notice. And then looking at your ECG to make sure that you're not trending towards bradycardia, and then treating early with an anticholinergic if you're having heart rate issues, or treating with ephedrine, whatever's indicated. You can usually avoid a lot of these issues. With a truly high spinal, this realistically could end up with you running an epinephrine infusion and needing to intubate the patient for respiratory support. And this would not be a common occurrence, but like most things in anesthesia, something you need to be aware of and prepared to manage if it were to occur.